Well, coming in.
Good morning, everyone. Welcome to Grand Rounds this Thursday morning. I'm Ava Kadiwara, one of the internal medicine chief residents. We'll go ahead and get started this morning, and I will introduce our speaker today, Dr. Presti. Dr. Rachel Presti is Associate Professor in the Department of Medicine, Division of Infectious Diseases here at Washington University in St. Louis. She's the Medical Director of the Infectious Diseases Clinical Research Unit, which in the last year has launched several trials for the treatment of COVID. Dr. Presti has been a leader throughout this pandemic in conducting the COVID-19 vaccine trials. This morning, she'll be delving into the science behind the vaccines. Thank you so much, Dr. Presti, for joining us here this morning.
And I'm afraid my title might be a little bit misleading. I'm not going to be talking extensively about science. My intent was to try to remind people of the science behind the vaccines and mainly to try to point out information that I think sometimes we forget that's actually critical for sort of understanding, and then to give you information to discuss the vaccines with, especially with your patients. So just to start, just a quick primer on the immune system. So this is what we're thinking about when you get infected with the virus, and for this particular diagram, it's actually off, but could be for any virus. So it initially would be infecting cells, and then you get an early innate immune response in the first couple of days after infection with a lot of inflammatory mediators, and then innate immune cells like NK cells, PMNs, macrophages, more cytokines, and then migration, especially of the dendritic cells to the lymph nodes, where you get antigen presentation to CD4 T cells, and they can instruct your CD8 killer T cells as well as your B cells to make an effective acquired immune response to the infection. So I know you guys all know that, but just as a reminder of what we're talking about, sort of the main sort of stage of infection. So that innate initial response, and then the acquired response is the specific response directed against that pathogen. Just sort of in another form, just looking really at the adaptive immune response. You have your antigen, your virus, that gets presented on an antigen presenting cell to CD4 T cells that then can educate your CD8 T cells, but also most importantly for what we're talking about in terms of vaccine response, the B cells. And then after you have B cells primed, just a recollection that you have both naive B cells that are making antibody and then memory B cells. And it's those memory B cells that are really critically important. So what we tend to measure are the antibodies, but it's that cellular response that actually gives you sort of the long-term, hopefully lifelong immunity to an infection. And again, because several of these vaccines are sort of a prime boost kind of thing, remember that after the first infection or the first exposure to a pathogen, you activate those naive B cells, and then you do develop long-lived plasma cells in the bone marrow. You make a lot of initially IgM and then IgG. And then when you see a repeat infection, you get a boosting of that immune response, improved antibody production, both in the activated B cells and in production of a lot of immunoglobulin IgG. But then also remember that you've got long-lived plasma cells in the bone marrow, B cells that are circulating, and those are actually important too. So even though what we're measuring is the IgG, when we measure the immune response, there's a lot of other things that are going on in the immune response, both to vaccines and to infection. So vaccines are designed to imitate the initial infection in a way that doesn't activate as much the immune system. It activates it in a very specific sort of way, but it still needs to go through the same process. So you still need something to activate the innate immune system and to trigger the whole immune response. And oftentimes what we use for that are adjuvants, although we'll talk about how the mRNA vaccines work and how they can sort of be their own adjuvant as well. So vaccines work, traditionally vaccines work by introducing a weak or inactive form of the disease. But more and more lately, we've been using subunit vaccines or now mRNA vaccines. So just a part of the pathogen. So not the entire pathogen. And then your body reacts by making antibodies, although their T cell responses are probably also important as well. They're harder to measure, but we know that they actually exist vaccines and for infection. So the antibodies, though, are what's really oftentimes important, and the neutralizing antibodies are what prevent the infection from being established again. So it's really critically important that you get a good antibody response to the vaccine because that's sort of the wall. And so you can kind of think of it this way. So when you're initially exposed to an infection, you get this chaos and invasion of the body. And so if you've vaccinated against, if you are able to recognize a threat, then you can have all this immunity already set up in place to prevent the infection from actually being established. Just a quick history on vaccines. So initially for several hundred years, what we did for vaccination was really use weakened or killed or even similar sorts of pathogens. So the initial vaccinations were variolation, so using cowpox to protect people against smallpox. And so even before we were aware of the germ theory of disease, we were aware that cowpox infection and even using small amounts of cowpox would protect people against smallpox. So the first lab vaccine then was created for chicken cholera. That was in the 1870s. And then the BCG tuberculosis vaccine was again attenuated bovine tuberculosis bacteria. So again, not using the same bacteria, not using the TB bacteria. And then we began using cell culture to grow things like yellow fever vaccine is growing yellow fever in chick eggs and then attenuating it by its passage in chick eggs. That vaccine is still in use, was developed in the 1930s. Oral polio vaccine was approved, and then rubella was approved in 1970. So the first subunit vaccine was really in the 1980s against hepatitis B. And so this is using the surface antigen from hepatitis B, so not the whole virus, not a weakened form of the virus, just a piece of the virus. And then we use that in combination with some sort of adjuvant. Sorry, I do a lot of HIV work. We've done a lot of HIV vaccine trials and clearly have not been as successful with those as we have, unfortunately, with the COVID vaccine studies. And then one of the first approved viral vector vaccines was the Ebola vaccine, and that was just approved last year using a VSV vectored Ebola vaccine. So the viral vectors are not replicating viruses. They are modified viruses. This was for VSV, but there are also adenovirus vector Ebola vaccines that have been used as well. And the vectored virus cannot replicate, but it is also modified so that it can express an antigen from the pathogen of interest. So for the vectored vaccines for COVID, again, we're using this So you can see it's been fairly recent that we've been able to do these more directed vaccines. And then the ones that are currently available in the US for EUA are the first mRNA vaccines, which people have been working on for the past 10, 15 years or so. There are a couple of advantages. We'll talk about the advantages and disadvantages of using nucleic acid to make your vaccine. So the mRNA vaccines basically use the spike protein from the coronavirus, and we'll talk about why we use that in a little bit. They use the entire mRNA sequence of that spike protein. So you will recollect from basic biology that the mRNA is the RNA that your body uses to code a protein, to tell your body how to make a protein, to tell your cells how to make a protein. And so, so basically, mRNA, the difficulty with mRNA vaccines in development really has to do with the fact that mRNA is not particularly stable. So your body and the environment, there is a lot of things that will degrade mRNA very, very quickly. And so in developing these vaccines, what they've done is made a few modifications to stabilize the mRNAs. And so we know more and more about how to do that. And so there are certain modifications you can make to the mRNA to make it slightly more stable. It's still not very stable. And then the lipid coating to make it something that you can inject into the body. So the lipid coating will allow it to be taken up by the cells. So the cells then take that up. The lipid coating around that will fuse with the membrane of your cells. So then that is gone. The mRNA is then in the cytoplasm. It never actually winds up in the nucleus. It's just in the cytoplasm. And it looks to your body like, to your cells like any other sort of mRNA. And your cells will make the spike protein because that's what it codes for. And so it makes multiple copies of the RNA itself, especially if it's sort of freely available. mRNA actually is immunogenic. It triggers the immune system because it looks a little bit like what you might see in a viral infection, triggers the immune system to make an immune response. So, so the mRNA is both the adjuvant, it's both triggering the immune response, and it's telling the body to make the spike protein. And so you make an immune response to the spike protein, you see an antibody response, but there's also T cell responses that you make to the spike protein in the context of these mRNA vaccines. The mRNA is then degraded over the next several hours, and you develop your immune response then against that spike protein. So what are some of the advantages and disadvantages of the RNA vaccine? So I'm not going to talk about the DNA vaccines because we're not doing those yet. But some of the major advantages of RNA vaccines, they're not infectious, they don't integrate, they naturally degrade. We don't grow them in eggs or cells or other things that are immunogenic or might cause problems or that you know, allergies that we see sometimes with people who have flu allergies. They're very, very easy to make. So it's easy to create an RNA vaccine. The production is scalable, and they stimulate your innate immune response. So they induce both a T and B cell response. So the main disadvantage is it has to do with instability. And that's because the RNA is not as stable. It tends to be degraded unless you can make those sort of modifications. And that's also why the RNA vaccines require the cold storage that makes them harder to distribute. So the viral vectored vaccines, those are the vaccines that the AstraZeneca vaccine and the Janssen vaccine that should be coming out hopefully in the next month or so. They also stimulate the innate immune response because they look to your immune system like a virus, even though they're not replicating. And they do induce both T and B cell responses. They are fairly easy to grow in the lab, but they do need to be grown in cell culture. And so they're not as easy to make as RNA vaccines. You can sometimes see, one of the disadvantages is you can sometimes see induction of immunity to the viral vector, which was one of the problems we saw with one of the HIV vaccines, the adenovirus 5 vector. People who had previous exposure to that virus actually wound up being more likely to get infected with HIV than people who did not have exposure to the Ad5 virus. And so because of that, the AstraZeneca vaccine is a chimpanzee adenovirus vector, so not something that we see in humans. And the Janssen vaccine is an Ad26 vector, which is much less common and doesn't seem to have as much sort of immunity, and that doesn't seem to affect the response as well. And again, the cell-based manufacturing is more complicated from a manufacturing standpoint, and so it is harder to make as many doses of the viral vector vaccines as it is the RNA vaccines. The other advantage, though, of the viral vector vaccines is they tend to be much more stable, and we can oftentimes distribute them without requiring the ultra cold storage that you need for RNA vaccines. Okay, so the next thing you need to make a good vaccine, you need your vector or your way of distributing it. And then the next thing is you need to know which antigen. And so I'm not going to give a whole lot of data on this. The antigen that's being used in all of the vaccines is the spike protein, and that's sort of shown here in this cartoon. These sort of blue spiky things that stick out in the little picture down below, the sort of classic picture that's put out by the CDC. It's these little sort of red spiky things that stick out. So you could see how it would be important to have an immune response against the spike protein because it is on the outside of the virus. And so you don't need the virus to actually be replicating for an antibody response against the spike protein to be able to clear that virus and hopefully prevent infection. One of the areas of the spike protein that we know is important is this receptor binding domain. That is the part of the spike protein that binds to the ACE2 receptor and allows entry. So we know that if you have antibodies against that, they're most likely to interrupt the ability of the virus to bind to its receptor and to cause infection. I do want to point out, though, that there are numerous other proteins in the virus, in SARS-CoV-2, including things like matrix protein and envelope protein, and then importantly, the nucleoprotein and nucleocapsid. So because those proteins actually are proteins that in natural infection, you make an immune response to those as well. It's not as clear how protective those immune responses are against repeat infection. In studies with earlier coronaviruses, it seems like the spike is the most important and most correlated with protective immunity. But you see those antibody responses as well, and that's actually important because they're used in some of our tests. So just like with hepatitis B, when you think about having a surface antibody, you could see that with both vaccination or infection. But when you look at the core antibody, you only see that when somebody's been infected. So for SARS-CoV-2, if you have antibodies against spike protein, you could see that both in vaccination or after infection. But if you have antibodies against the nucleoprotein, you only see that after natural infection. So here's just a little bit of some of the animal data. This is actually from the Janssen Ad26 vector, showing you that in animals that were infected with a sham, or not infected, were injected with a sham vector that doesn't contain the spike protein and then subsequently infected with SARS-CoV-2, you see a lot of viral replication in those animals. And in animals that were injected with or vaccinated with the Ad26 vector that contained a version of the spike protein, you can see very, very good protection. And actually just yesterday, so I didn't get these but we are seeing, they just published the phase 1, phase 2 results from the Janssen vaccine studies demonstrating good immunity and expected protected immunity against SARS-CoV-2. So again, I sort of mentioned this already. The vaccine antigen is spike, but again, you get multiple antibodies against SARS-CoV-2. The key point for this is that most of the commercial tests, including the one that we use at BJC Hospital, that is the antibody test against SARS-CoV-2, is directed against the nucleoprotein, not against the spike protein. So if you get vaccinated and you want to know how well protected you are, and you go and get your antibodies checked, and you get very, very sad because you have no antibodies, it is because what we're measuring is antibodies against nucleoprotein, and you wouldn't have those after vaccination. You would have those only after natural infection. And so that also means that you can use that to see if people are getting infected post-vaccination in a way where they aren't symptomatic. We can also see if they make an immune response to the nucleoprotein, suggesting that they've been exposed to SARS-CoV-2. Okay, there are other ways of preventing infection that include monoclonal antibodies. And if we treat people early, potentially, with monoclonal antibodies, they may actually also protect people from severe disease. So those are actively being studied, but just kind of comparing the two, the antibodies generally last weeks to months. Hopefully your vaccine will last years to lifetime. You may need some boosters, but antibody therapy actually works right away and can be used to directly treat somebody with SARS-CoV-2 or to prevent infection in somebody who's been exposed. So there's still potentially a place for antibody therapy for early infection or to treat somebody who's been exposed and where you don't have time for vaccination. So the vaccine, again, takes a while, usually 1 to 2 weeks after vaccination, before you start to see an immune response. And so sometimes you don't have that much time in an exposure situation. But it's important to think about the monoclonal antibodies because they do last for weeks to months. In general, we say an antibody after an infusion lasts about 3 months. It will affect your response to vaccine. And so if you have antibodies around, they will clear the spike protein that's being made by your vaccine, and then your own immune system won't figure out how to do that. And if your own immune system hasn't figured out how to do that, you won't have those memory B cells and you won't have those antibodies lasting for your lifetime. You'll have antibodies from the monoclonal antibody that lasts only for a couple of months. All right, so on to vaccines. So this is a little bit old, but there are numerous vaccines in preclinical development and in early stage development, but more and more that are being approved for either limited use. So the EUAs would be considered limited use. This is sort of worldwide. There are vaccines that have been approved for full use in other countries, none yet in the US. Part of that has to do with the way the FDA does this. And because we consider the coronavirus to be an emergency situation, they are allowing an emergency use authorization for the vaccines. It actually doesn't mean that there's significantly less data that is required. There's less time of follow-up that is required to get an emergency use authorization. But the data is very similar to what would be used for the full approval of the vaccines. And because it's available then after emergency use, there's not as much of a time pressure to get the vaccine approved for full use in the US. It just has to do with the way our regulatory system works. And the one vaccine that was abandoned after trials was the Australian vaccine. And there was something about the way they had designed it that wound up giving people false positive tests for HIV. So since that is going to be a problem moving forward, to have a whole bunch of people with false positive HIV tests, that vaccine candidate was abandoned. All right, in terms of vaccine development, we've talked about this a little bit already. The two vaccines that currently have emergency use authorization are the Pfizer vaccine and the Moderna vaccine. Both of those are RNA vaccines. So a newer version of, or a newer way of making a vaccine, but clearly quite effective. Both of them are around 95% effective and easy to make, which is why those were the first vaccines that went into trials. And the next vaccines that went into trials were AstraZeneca and Janssen. Those are those viral vectored vaccines. Again, none of these vaccines are replicating or infectious. And so they can be used in people whose immune system isn't as strong. They weren't tested necessarily in that setting because it's hard to tell if you have protective immunity, if you're not sure if your participants can actually generate an immune response. And then there are other vaccines that are in development. Sanofi is actually quite a bit behind. They had some problems with manufacturing and their initial doses were too low. And so they are redoing their phase 2 studies with a higher dose. Novavax has ongoing phase 3 studies that are going on now. Those are both recombinant protein vaccines. So very similar to the hepatitis B vaccine, where you're just using the spike protein itself with an adjuvant to give you an immune response. So the RNA vaccines and the viral vector vaccines are their own adjuvants. The recombinant protein vaccines need something else that will stimulate the immune response so that you get an immune response against the spike protein. There are other vaccines, inactivated vaccines. One of the Chinese vaccines is an inactivated SARS-CoV-2 virus. There are no live attenuated vaccines that are in development to my knowledge at this point. These are the 4 vaccines that are the 2 that already have emergency use authorization, and then the 2 that we're expecting to have evaluated fairly quickly. Again, just to point out, and I think I've said this multiple times in other settings, but these were done in very, very large numbers of participants. So the Pfizer BioNTech had 43,000 people enrolled in their phase 3 study. Moderna had 30,000 people enrolled in their phase 3 study. AstraZeneca has 30,000 people planned enrollment, which should end this week. And that's just in their US study. They have tens of thousands of folks enrolled in other studies in the UK, in South Africa, and Brazil as well. And so that data will be available, but there were some concerns about the processing of those trials. But that's where the preliminary data comes from, not from the US study, but from those other trials. The effectiveness is thought to be around 90%, although somewhat variable. Some of the variability in this has to do with the fact that they were actually looking to some extent at very low levels of symptom or even asymptomatic infection. And so depending on how you count the numbers, all 3 of these so far, Pfizer, Moderna, and AstraZeneca, have been very, very effective against severe infection. And then somewhat less effective against less severe infection. And then it's not entirely clear how effective they are against asymptomatic transmission, which is why we're telling people after you get vaccinated, you still need to wear a mask, socially distance until we can get the pandemic under control and until we can get more people vaccinated. I also want to point out, especially when you're talking to your patients or colleagues who may be concerned about this, there was early concern about not having enough people of various race and ethnicity enrolled in these studies. And you can see actually in all of these studies, about a third of the people enrolled in the studies are people of color, so not Caucasians in the US studies. And then obviously in the non-US studies, they would reflect their local populations. Also, all of these vaccines were studied in a large proportion of people who were older, including at least 25% of people over the age of 65. The effectiveness of Pfizer and Moderna has been about 95%, and you can see the initial numbers that were reported, although there are more cases that have continued to be accrued, and we will see more data coming out. There are 2 doses for Pfizer, Moderna, and AstraZeneca, given 21 days apart, 28 days apart, or 30 days apart. The Janssen vaccine, the way it is currently being developed, is a single-dose vaccine, although there is another study where they're doing a second dose at 57 days. The phase 1/2 data that just came out does demonstrate that you get what is thought to be a protective immune response by 57 days. So before even that second vaccine would be given, 100% of people in those studies had developed antibodies. The side effects are somewhat what you would expect. Fatigue, headache, the percentages shown here are for fairly severe side effects that were affecting people's ability to work for a short period of time or do their normal activities of daily living. So fatigue, muscle pain, joint pain, headache seem to be the most common side effects for the RNA vaccines. We'll talk a little bit more about in the rollout of the vaccines, we're seeing allergic reactions and what we're seeing with those as well. And again, that cold storage temperature that you need for the RNA vaccines. And then again, I'll talk a little bit about transverse myelitis and other sort of neurologic side effects in just a bit. Just to compare, because people are concerned about these vaccines being developed too quickly. They were developed quickly, but that's because we're in the middle of a pandemic, and that's because there are so many people getting COVID-19 right now that you accrue cases very, very quickly. So there were also a lot of people enrolled. So compared to 30 to 45,000 people enrolled in the COVID-19 vaccine studies, if you looked at the Shingrix vaccine study, sort of one of the most recently approved vaccines, there were only 15,000 people enrolled. And you can see that the case numbers that they used for approval were very similar to the case numbers that we saw in the COVID vaccine studies. But it took 3.5 years to get those, whereas these cases actually accrued in 2 to 3 months. So the same is true for the pneumococcal vaccines. There were even fewer people involved in the phase 3 studies for hepatitis A vaccine and hepatitis B vaccine. And again, influenza vaccines, sort of the last pandemic pandemic vaccines that were developed, because they were flu vaccines, did not require as much testing of their efficacy. And so most of that was a retrospective analysis. Efficacy for the pandemic flu vaccines was about 56% compared to the 95% that we were seeing for the COVID-19 vaccines. I think this is really all you need to show people in terms of how well the vaccines work. And so the large figure here is showing for the Pfizer vaccine the number of cases. And so cumulative incidence by percentage of people. And you can see that actually, so you have a dose at 0 times 0, and you have a second dose at 21 days. And you can see that there is actually protection very early. So those curves actually begin to diverge, before 2 weeks. Around 10 to 12 days is when we see those curves initially sort of start to separate. And then they, it just continues, and you see very, very good protection out, for the duration that they've looked, which is around 3 months or so for this vaccine at this point, you can see a considerable protection against infection for the Pfizer vaccine, and the same is true for the Moderna vaccine. Maybe a little bit longer to start to see those curves diverge. So more like 12 to 14 days is when you see those curves start to separate. But then you can see significant divergence between placebo and the vaccinated folks out for several days post randomization. So the data is very, very clear that these protect people against SARS-CoV-2 infection, and particularly that they protect against symptomatic disease and are very protective against severe disease. So what's on the other side of this, the adverse events, and one of the major things that people have been concerned about are allergic reactions. So this is actually looking at allergic reactions after the initial rollout through, excuse me, through the end of December for the Pfizer vaccine. And so this is almost 1.9 million people got their first dose, with 4,393 adverse events submitted to the vaccine adverse events reporting system. Of those, about 175 were possible allergic reactions. 21 met the Brighton criteria for anaphylaxis, and this is shown here. So 21 people out of 1.9 million had an anaphylactic response. So concerning, and we have had folks locally post-vaccine with an anaphylactic response, but very, very, very low numbers. So compared to the risk of COVID-19 in a population at high risk, the safety profile is actually quite good. So anaphylaxis response, the median age of people was 40. Most were women, and the response for anaphylaxis occurred, within around 13 minutes on average, but up to a couple hours after the injection. Symptom onset most of the time occurred within 15 minutes and mostly within 30 minutes. Many of these folks had a documented history of allergies or other allergic reactions, including anaphylaxis to other vaccines or other drugs. For the non-anaphylactic allergic reactions, so 83 were reported. A little bit older, again, much more often female, similar sort of onset in terms of range or median onset, although up to 20 hours post injection, and a little and similar sort of in terms of timing. Fewer of these folks had a documented history of allergic reaction, but most of them again did. So we are seeing some allergic reactions. I think this was a bit of a surprise, given that we wouldn't have thought that mRNA would be as allergenic, but that is the data we have so far. There also are some neurologic adverse events that people should be aware of. One of the ones that's gotten the most attention is Bell's palsy. So in the clinical trial for Pfizer, so again, that was 44,000 people. 4 people experienced Bell's palsy. All of those were in the vaccine group, and there were no cases in the placebo group. In the Moderna trial, 3 people experienced Bell's palsy in in the vaccine group, and one person had Bell's palsy in the placebo group. So the numbers are very small. I think it's a little hard to say definitively that this was due to the vaccine, but it could be. The other thing to point out is that the incidence of Bell's palsy in the US annually is about 0.01%. And the incidence of Bell's palsy in the trials is around 0.01%. So it's a little hard to know whether or not this is due to vaccine or this was something that was going to happen in these participants anyways from other causes. And you can see again the timing of this. So there were folks, in the Pfizer vaccine as early as 3 days after vaccination, but up to 48 days after vaccination. And the folks in the Moderna trial all occurred. 2 of them occurred after the second vaccine. The third occurred slightly before the second vaccine. The other thing that has been reported, not in the mRNA vaccines, but in the AstraZeneca vaccine trial, there were 3 cases of transverse myelitis reported in that study. One occurred 14 days after vaccination, have been related to the vaccine. One actually occurred in somebody who had pre-existing multiple sclerosis with evidence of prior MS on imaging. So the transverse myelitis in that case was thought to be due to multiple sclerosis. And there was a third case of transverse myelitis that actually occurred in the placebo arm. So it is hard to know whether or not that single case was due to the vaccine, but we cannot rule that out. There are also concerns about Guillain-Barré post-vaccination. Very, very few cases. In fact, I'm not aware of cases that have been reported to date. There have been cases of Guillain-Barré associated with COVID-19 infection. And we should remember that COVID-19 is associated, the infection is associated with several neurologic manifestations. So headache, obviously the loss of taste or smell, delirium, strokes, seizures, encephalitis. There are cases of transverse myelitis in post-COVID-19 and ADEM as well. Okay, moving on to special circumstances, people who were not studied in the trials, so important groups that were not studied. So people who are pregnant were not studied, people who are pregnant or nursing were not studied in the mRNA trials, vaccine trials. That is mainly due to the concern about testing something in pregnancy. So there are hopefully moving forward, but generally we want to establish safety and efficacy in a healthy population that is not pregnant before we move to pregnancy, just in terms of the desire to keep pregnant women safe. So the vaccines, though, are not live vaccines. There are not safety concerns in animal studies for pregnancy, and COVID-19 infection is demonstrably more severe in pregnancy. So outcomes are worse in pregnancy than they are in the general public. And because of all of that, the ACOG is recommending vaccination for people who are pregnant. And there are studies that are planned for both pregnancy and breastfeeding that are ongoing. The Janssen vaccine is being tested. So pregnancy is not allowed, but breastfeeding is allowed for the Janssen vaccine study. It was not allowed in the other studies. And the Janssen Ebola vaccine that uses the same vector has been approved for pregnancy. So there's data in pregnancy for that vaccine. So in general, we think if the risk benefit is reasonable in discussion with a pregnant woman, especially a healthcare worker who is pregnant, the recommendation would be to go ahead and get vaccinated. The second group that was not studied in the trials are people who are on medications that would suppress the immune system. And there really isn't a concern for safety in that population because, again, the vaccines don't contain live or replicating virus. So there's not a safety concern in immune suppression. The concern is that the efficacy may be lower. And so there are ongoing studies looking at people who are being vaccinated, who are on immunosuppressive medications to see how well the vaccines work in that population. Okay, other special circumstances. So in people who have been infected with COVID, the recommendation is that you should definitely wait until you've recovered from the COVID infection, but that you should get vaccinated. So there are cases of reinfection with COVID-19, and so we think that the vaccine will provide additional protection. It's not clear how long immunity lasts post-COVID. And vaccines should be helpful. If you look, about 7% of people had antibody evidence in the baseline infection in the clinical trials. So for some of the clinical trials for the vaccines, known COVID infection was excluded. Not all. Some of the vaccine studies were done without excluding people who'd had prior COVID infection. But there definitely were folks who enrolled in the studies even without known COVID who had antibody evidence of COVID infection. And in general, the vaccines were determined to be just as safe in that population and just as effective in that population. So the recommendation is to go ahead and get vaccinated. In general, you should wait until you've recovered from COVID before you get vaccinated. And there is data that suggests that you probably have protective immunity for at least 3 months. And so there is some thought that you could wait to get vaccinated, for 90 days after a COVID infection, if that was desired, and you're probably safe for that duration. The situation, if you've had COVID and you were treated with a monoclonal antibody, is slightly different in that the recommendation then is to wait at least 90 days because the antibodies are going to be around for that long, and they would interfere with the generation of an immune response. Our next sort of situation to talk about are the novel variant viruses. There are 2 that have been well described, one from the UK and one from South Africa, variants of concern. Both have mutations in the spike protein. The UK one has one in the receptor binding domain of the spike protein. Currently, the thinking is that they still will be prevented by vaccines, but we don't have direct data on that, and so that is being evaluated. There is some emerging data that they may not be as susceptible to monoclonal antibodies. Most important about these variant viruses is that they appear to be more transmissible. They appear to be more infectious, and so that is probably a reason why the UK is seeing such a large spike in new cases right now, because these viruses seem to be transmitted much more efficiently. They don't appear to be more severe in terms of disease. They don't appear to have a higher mortality, but if you have more people infected, you will have more people dying from COVID-19. And the concern is that we think these are potentially arising in people who have long-term shedding, and we don't know exactly whether or not future variants will escape pre-existing immunity, whether or not they'll escape monoclonal antibodies or convalescent plasma. So the poly response then in convalescent plasma may be more effective than a specific monoclonal antibody. And then we don't know whether or not they will eventually escape vaccines. And so the emergence of these variants and continued study of new variants of SARS-CoV-2 will be really important and will probably inform whether or not a single vaccine is going to work, or whether or not we need boosters, or whether or not this is going to turn into something that's more like influenza, where you may need a variant vaccine more frequently. So that is all information that I don't have a crystal ball for, but is all potential. Speaking of the duration of immune responses, so antibody responses to spike, these are in people who are post COVID. They're variable, but they do seem to initially decline so much, and then they're fairly stable over 3 to 6 months post-infection. They do elicit long-lived bone marrow-derived plasma cells, a robust memory B cell response. And so just looking at the antibody responses doesn't tell you the whole story. It does look like there are long-term memory responses, even if the antibodies decline. So people who are checking their antibodies and are concerned that they need another booster vaccine, or they're not protected, it's probably not the best way of knowing if you're protected. And so we do know that memory T cell responses are elicited, and from the original SARS, people who recovered from SARS actually still have evidence of memory T cell responses even now 17 years later. So there are long-lived immune responses. How protected they are is still under investigation. Okay, I wanted to talk really quickly in just the last little bit about sort of some conspiracy theories that you may hear, and my advice as to how to respond to them. The first is that the vaccine could cause infertility. This is a rumor that is from a Pfizer, originated from a former Pfizer employee who's against the vaccines, suggesting that the SARS-CoV-2 spike protein is similar to Syncytin-1 in the human placenta. I'm just showing you here that they don't look remotely similar. So these are the ribbon diagrams of those two proteins. The suggestion is, excuse me, that this similarity would result in damage to the placenta and pregnancy loss or infertility. The immune response is the same to the vaccine spike as it is to spike in people who have had COVID-19. And the current data demonstrates similar pregnancy outcomes so far, both early and late trimester in women with prior COVID-19. Not just looking at this, but blast analysis, there's no real significant similarity between spike protein and Syncytin-1. And arguing against the vaccines causing infertility, 23 women became pregnant while they were on the Pfizer vaccine study. Insofar as men, there's really no data available that suggests that vaccines would impact male fertility. There's not really a plausible mechanism for how that would happen. There is some data that SARS-CoV-2 does infect the testes and may affect fertility in men. Those are very, very, very sort of limited data and still under study. So if men are worried about fertility, the vaccine is going to definitely be better than infection. There's also concerns about the mRNA vaccines integrating into your DNA and causing cancer or mutations or so forth. They are not integrating. There's no reverse transcription of the mRNA vaccines and integration of that DNA back into your DNA. The RNA is unstable. It's not infectious. It's degraded by normal cellular processes, and so there's no reason to think that the mRNA vaccines would enter into your DNA, and there's no evidence that happens. Moving even further into conspiracy theories, this has been a conspiracy theory for multiple vaccines that that microchips are being placed in the vaccines and used to track people. I don't have a real good argument against that. I think it would require tremendous coordination across multiple vaccines. It would be very difficult given that these vaccines are given out of multi-dose vials. I don't know how you would make sure that you knew which tracker went into which person. And if you were really wanting to track people, it'd be far easier to track people with their phones than trying to track them with a microchip given via vaccination. So it's also not clear. I think a microchip would still be visible in the vaccine, and we're not seeing that in those vaccine vials. There's still a whole lot more that we need to know. We're still doing ongoing studies, including if you are getting vaccinated and you're interested, please contact us. We're looking at post-vaccine antibody responses. Dr. Kim is looking at antibody responses after vaccination in people who are in immunosuppression. Dr. Kendall is looking at allergic responses post-vaccination. Dr. Ebony Carter in OB is looking at responses in pregnancy and breastfeeding. And then Dr. Babcock and Kwan are looking at post-vaccination infections. And so lots of work still ongoing. If you're interested in knowing more about those studies or participating, feel free to contact me. So just to conclude, the vaccines are safe and effective in a lot of people, and very, very similar safety profiles to other commonly used vaccines. Just want to thank the volunteers and the scientists and research staff who've made this possible. I guess I'll take a look at, okay, so questions. I see 4 questions. It looks like passive immunity, the monoclonal antibodies. So monoclonal antibodies, I think potentially could be effective if they're being used very early in disease or as a prevention mechanism. The problem with them is that they're, it's been very, very complicated to figure out how to administer them. They require infusion and monitoring. There are infusion reactions afterwards. I think that there's also concern with these variant viruses that are coming up that we might actually be giving monoclonal antibodies in people who have had prolonged infection may actually result in speeding up the development of variant viruses that escape immunity. And so I think we do want to look at monoclonal antibody as really in a very, very select population, very, very early in infection. I think that's the only place we're going to see a lot of benefit. And I do think there's a risk to giving it in people who are sicker and farther along in infection who may actually wind up with developing resistance variants to those antibodies. There is no risk for people with immune compromise to receive a viral vector vaccine. Those viral vectors are not viruses in that they don't replicate. So there's no shedding, there's no replication of those viruses. Anaphylaxis in other vaccines, seeing the sex difference in the Pfizer. I would have to look at that. I apologize. I hadn't looked at that, and I don't do a lot with allergies, so that would be something to defer to the allergy folks, and I can talk to Dr. Kendall and see if we can get an answer on that. The Chinese vaccine is not as effective in the Brazilian population. I think there are going to be differences that we see between the vaccines in terms of efficacy that are going to depend on a couple of things. Partly, it's going to be, vaccine efficacy intrinsically. Partly, it's going to be on how they're measuring cases. So if they are measuring asymptomatic, if they're screening for asymptomatic infection, either using an antibody test or screening with swabs for asymptomatic replication, I think you're going to see a lower efficacy against that. And then also, I think it's going to depend a lot on when in the pandemic you're looking. So I think you're probably going to see lower efficacy in a population with very, very, very high transmission. And you may see less efficacy in populations with some of these variants. So unless we were doing head-to-head testing between two vaccines, I think it is a little bit harder to say this vaccine is definitively better than this vaccine. Can two people both vaccinated feel comfortable to take their masks off? We don't know the protection against transmission. I think your risk is lower. You know, it may be that you want to have that particular person in your pod, in your group of people that you feel comfortable with, taking masks off. But I think we need to be very, very careful looking at stopping using masks based on vaccine levels. Sorry, I will try repeating the question a little bit more. Any thoughts on injecting in the same arm or different arms with different draining lymph nodes? I think people were using the same arm for the vaccine studies. I think there is interest actually in looking to see if the immune response is different, but I don't think it's that much of a difference if you use a different arm. So because you are you know, you're probably better off using the same arm to activate the same germinal centers. But if you had to, it would probably be okay as well. And then there's a question about anti-vector immunity, why it was a disadvantage in the other vaccines. I suspect it has to do with how the immune system took up that vaccine. And so it may have actually cleared the vaccine. It may have induced a situation where you had antibodies produced that actually weren't protective, but actually sort of brought in sort of enhanced transmission. And I think that's what we thought was going on with the Ad5 HIV vaccine. There's a question about kids getting vaccinated. So the Pfizer vaccine was tested down to age 16. There are ongoing clinical trials for Pfizer and Moderna for age 12 to 17. And they are planning trials for kids under age 12. There also are, Janssen's also planning vaccine trials in kids as well. They will need a separate clinical trial for safety. I think in general, the assumption is efficacy has probably been similar. And so they probably don't need as large of clinical trials. They will want to look at efficacy, but they may not need 30,000 kids. They may need, I think the Pfizer study is 3,000 kids to look at immune responses and then to look at efficacy. Recommendations regarding timing of vaccine administration with respect to biologics. There is a whole group of folks in rheumatology who are working on advice for that. In general, we wouldn't recommend, if somebody needs a biologic, we wouldn't recommend changing the timing of giving those if people need them for underlying disease. And then, you're probably better off giving the vaccine sort of later, after a biologic, but given the tight timing in terms of access to vaccines, I would probably just sign up for getting the vaccine done. What host cells are making spike protein? I think those are probably dendritic cells that initially take up the protein, but then just the cells in the muscle that the vaccine's been injected into. So any of those host cells are making spike protein. The nasal vaccine developed by Mike Diamond, David Curiel. I actually don't have an update on that. I would defer that to Dr. Diamond and Dr. Curiel. I haven't heard anything for a while as to how that is progressing. I know they were looking for partners for development. My thoughts about opening vaccine to everyone and not having stockpile for second dose. So it's clear from the trial data that there is immune response that occurs even before the second dose. There is a protective immune response before the second dose. And I think we need to do a better job of getting people vaccinated. So if we open vaccination to everybody and not keep stuff back, and on the assumption that we will have vaccine that becomes available to give the second dose, I would be in favor of doing that, just in terms of developing the system for actually getting vaccine to people. Okay, so those are the question and answers.
Yeah, thank you so much, Dr. Presti, for going through all of those in the Q&A. Some people put some in the chat. There's one in there that's a clinical scenario that I kind of want to bring forward to you. In this case, it's a elderly patient in a nursing home, was diagnosed with COVID about 1 week after her first dose of the Moderna vaccine. Is there a role for monoclonal antibody after receiving the first dose of vaccine?
I probably wouldn't. A week after the first dose of the vaccine, the monoclonal is going to interfere with generating an immune response in that setting. And so I think you're already starting to make an antibody response. And I think that the other question behind that is then when do you give the second dose of the vaccine? And I think you probably just need to wait until they've recovered from COVID before you do that. And so that could potentially delay that second dose.
And that was actually the follow-up to their question too about the timing of the second dose if there is a COVID infection between the first and second doses. So you would just the delayed second dose then. Great. Okay. Well, thank you so much. We're already 8 minutes past the hour.
I'm sorry.
Every single person's questions. I know a lot of these in the chat you did hit on throughout your presentation as well. So thank you, Dr. Presti. Thank you for those of you who are still on with us as well. Dr. Presti, I don't know if you can see the questions in the chat. If there's
there's
anything that kind of strikes your fancy and you want to follow up on, I could help coordinate that as well.
Let me see if there's easy stuff at least. So there's the nature of the allergic reactions. I think that is still under investigation, what the allergic reaction is, what exactly it's against, and whether or not they should not get any mRNA vaccine ever again, because it's either the lipid bubble that you put the vaccine in, or if it's something about the response to the mRNA. Clearly, the mRNA vaccines are more reactogenic than I think we thought they were going to be. So people do have more symptoms than we thought. There are definitely ongoing studies to look at transmission from vaccinated people. So I think I'm not aware that we're doing anything here locally, but I know there are lots of people who are doing surveillance in especially in healthcare workers that are getting vaccinated. The placebo in these in the phase 3 studies was saline. In some of the earlier studies, they maybe used another vaccine as a placebo, but But in the large scale studies, it was just normal saline. This is the nursing home resident. Yeah. So there's a question about if the lab testing be similar to hepatitis B situation then. Yeah, I think it becomes important then to know what antibody test that you're getting. And it's interesting, but it actually is fairly hard to find that out sometimes, whether or not nucleoprotein or spike. And so I think it will become important moving forward that when we are doing a serology test, that we know what the serology is actually directed against. A positive nasopharyngeal test suggests it doesn't tell you that you've got actively replicating virus. So you know, we know in people who are post-COVID that after 10 days, they're not shedding active virus, replicating virus, but there's still, it's a test for nucleic acid, and it may be present for quite some time. So since we don't use that, I think if you have a new nasopharyngeal swab that's positive, that's got to have come from someplace. But it is going to be important to not just do nasopharyngeal PCR testing, but to also do testing of whether or not there's actively replicating virus, because that would be important for transmission. Autoimmune disease flare with mRNA vaccination. Not that I am aware of. The trials were not done in people with autoimmune diseases. So this is all going to happen, I think, in people who have autoimmune disease that's well controlled, who get the mRNA vaccination. I think we're going to want to know what happens in that. That I think, unfortunately, is going to probably wind up being either in future studies or in what happens in the real world. A few Chinese students on the Danforth campus have received inactivated virus COVID vaccine in China. Should they be offered an FDA-approved vaccine when college students get vaccinated in the US? Given the limitations on vaccine right now, I think if you've gotten a vaccine that has shown efficacy, then we get people who've not been vaccinated vaccine. When it's more widely available, hopefully there would be more data available, but I actually probably would leave that to the occupational health and student health folks as to whether or not we should be requiring that. I think offering people is fine. We don't have data yet, although I expect we will have data given the way things are going, as to what happens if you get more than one vaccine. I would expect you have more side effects and symptoms than if you had not. Is it necessary to quarantine after exposure if one is vaccinated? I think right now that is still the recommendation. I would defer that question to occupational health. But because we don't know about asymptomatic transmission, I think, yes, you probably want to be quarantined after exposure at this point. Insight into the proposed vaccine rollout to the population at large. I don't know what that, I don't have any insight into that. How do I answer a young person who says my risk of getting a severe infection is even lower than developing a severe anaphylactic reaction? I would disagree that it's lower than developing a severe anaphylactic reaction. If you had a young person who had already had anaphylactic reactions to other vaccines, then yes, maybe the risk would be lower. But we're seeing infections in kids now, even in young healthy people. I think you still need to talk to them, and it's still obviously people's decision about whether or not they want to be vaccinated. But But I would say the benefit is still there for younger people as well. I don't think it's worthwhile checking antibody levels to see if you responded to the vaccine at this point. I think that will be something that we develop as we move forward. Autoimmunity, I don't think we know anything about how the vaccines might be. If they've had COVID, you should vaccinate people. I think that's it.
I think you did it. Thank you so much, Dr. Presti, for taking that additional time to get to everyone's questions. I know for sure that your talk has helped me in, discussing the vaccine with patients, discussing the vaccine with people in the community, and answer some of the questions that I've seen come up at the vaccine clinics as well. So thank you so much for taking this time. It was very popular. I think we had up to like 200 people on at a point. So thank you for your time.
Thanks.